Dr. Jeremy Finkelstein is on the front lines there. He is the director of the emergency department at Houston's Methodist Hospital. Joins us now. Doctor, welcome. It's good to talk to you tonight.
Well, thank you for having me.
How concerned are you this evening?
Well, I think, some of this was anticipated, right? I mean, Texas was one of the first states to reopen its economy and kind of get things moving again, albeit with some restrictions. So I don't think it's a shock to anybody here. On the other hand, it's a flag of caution. We are certainly watching the numbers very carefully and gauging our response to that accordingly. If you look at the way Texas orchestrated the opening of the economy in the state was they put a mandate that hospitals had to reserve a certain amount of bed capacity, inpatient bed capacity for COVID-related illness at about 15%. And so that's really a statistic that we're watching very cautiously and huddling with other area hospitals. We're not doing this in a vacuum. This is being done in concert, kind of in an unprecedented manner with other hospitals in the catchment area here.
Was going to say Governor Abbott today saying that he's concerned but not yet alarmed. Does that match sort of your feeling tonight?
Yes, I think that's a pretty accurate statement. We've only got a couple of days of trend, and so we're watching that very cautiously. As I mentioned, we never really fully disbanded our incident command, and if you've looked at some of the news media recently, states like Arizona and others mandating the reinstatement or the opening of incident commands to coordinate these efforts. Here at Houston Methodist, we never dismantled that apparatus. So I'll give you an example. In the peak of the pandemic, we were doing calls, 3 times a day with incident command with all our executives and all the relevant hospital leadership and relevant departments. We're now down to 3 days a week. So Monday, Wednesday, Friday, we do a call. But we've never really disbanded that with the thought that if we did have a second wave or a flare up, we'd be ready to go and ready to kind of jump right back into action. So that whole process is still unfolding and still active here in Texas.
How close to capacity is your hospital?
And I assume you're mentioning about the 15% COVID capacity issue. So we have plenty of bed capacity. And in fact, during the height of the pandemic at the peak, which was kind of late April, early May, we really never bumped up against a capacity issue, especially in the critical care areas. And I think that's the most important, right? The sickest of the sick patients. Those are the folks that consume the most resources. Those are the folks that put the strain and stress on the healthcare system and push it to the edge. And we really never even bumped up against that. We had adequate PPE throughout the entire process, unlike many areas in the country that were very hard hit. So I guess we were lucky to an extent that we didn't reach those numbers. Currently, we're approaching this as a system, right? And we have 7 acute care hospitals, 8 freestanding emergency departments in our system. So there's plenty of bed capacity, whereas one hospital may bump up against a wall with closer, 85, 90% capacity, but we have plenty of capacity system-wide. There is an important point I do want to make, which is, we have to learn how to function now in a system that's bifurcated. And what do I mean by that? During the pandemic, we had 2 to 3 months where patients literally avoided the ER for serious medical problems. And so morbidity and mortality rose significantly, and that's well documented throughout the country. People avoided ERs for strokes, heart attacks, cancer-related illness, sepsis, severe life-threatening situations. EMS providers will tell you that they made more calls for, unfortunately, dead bodies at home, for lack of a better term. Cardiac arrests occurred because people refused to come to the hospital for fear of catching COVID. So hospitals have to learn to function now in this environment. How are we going to provide those services for both sets of patients, the COVID-related patients as well as the non-COVID-related patients? We can't go back to closing down entire service lines and surgical procedural areas en masse again, because those patients are left behind, and the unfortunate outcome is not good.